to prevent this fracture disease. To prevent a fracture disease, you must mobilize the affected limb. If you have early mobilization after fracture fixation, this will prevent the fracture disease. How to move the limb but hold the fracture? To prevent this phenomena or points of fracture disease, internal fixation, of course, is the solution for this problem. Early movement and fixing the fracture. Before the AO, results of internal and external fixation were usually worse than non-operative treatment. Unfortunately, I was a resident at Ain Shams University Hospital, the Demirdash Hospital, and Professor Hassan Elzoheriy, he is the pioneer, one of the pioneers, and one of the our girl professors that introduced the AO for Egypt. I was the resident at the Ain Shams University, and usually we try internal fixation and external fixation, but our results were worse than non-operative treatment. Cast, reduction of fracture and applying cast is more beneficial for the patients at that time than internal or external fixation. And you shall see what is the cause for this. Internal fixation was usually accompanied by prolonged immobilization. At that time, usually we did internal fixation and apply plaster after operation. يبقى العيان عمل عملية تثبيت داخلي للكسور والمفاصل يتبعها جبس. يبقى this is will not benefit to the patients because we need early movement to prevent fracture disease. Robert Dennis applied plates to fractures, and this is the first to use compression for fractures by plating. He discovered the first to discover primary union could occur without callus formation. You know, our doctors, that we have two types of union. It's called the primary union. That is direct union between the two ends of the fractures, and indirect union, that is with callus formation. The primary union without callus formation, and this is needed in articular fractures because we don't need callus inside the joint to not preventing the full range of movement after union of the fracture at the joints. But in diaphyseal fractures, we need callus formation. So we have two types of union, primary union and secondary union. Morris Muller was the first and pioneer with Robert Dennis to start treating of fractures by internal fixation in 1950. Between 1950 and 1956, they performed 58 open reduction internal fixation, and all of them were documented. In 1958 was the formation of the AO. As you see here, Professor Muller, while explaining and trying the workshops for internal fixation with Robert Dennis. The pioneers of AO for internal fixation were Professor Morris Muller, Robert Schneider, Hannes Wallenegger, Walter Algoer, and Walter Bandy. All of them from Switzerland, Germany, and Austria. These are the pioneers of AO. AO started in 1958 by putting the AO principles. All fractures must be anatomical reduction. All fractures, articular or diaphyseal or metaphyseal, all fractures must be anatomical. All fractures must be fixed by rigid, stable fixation. What is the meaning of rigid internal fixation? That is no motion at the fracture site, no micro motion at the fracture site. So will unite by union, primary union. So our first trials, even in Egypt in 70s, as I shall show you now, all fractures, anatomical reduction, rigid fixation, and the number 3 is the preservation of the soft tissue. 4 is the early active motion. As we see in this picture, this is the first workshop of internal fixation at Davos, Switzerland. Here is Muller with Dennis and his colleagues. At the same time, you see ORB, internal fixation course, was done in parallelism with this course. So the success of our operations, internal fixation operations, must be with clever and educated ORB. And now you know that is ORB basic, ORB advanced, and now AO challenging them by preparing them for ORB fellowship in Switzerland, Germany, and Austria. And some of our ORB from Egypt got this AO fellowship for the ORB. It's very important to educate your assisting ORB during your operations to get the more success. After they putting the rules, Rudy from Switzerland, Algoer from Germany, documented 487 consecutive tibial shaft fractures treated by plating. They started to apply this concept that anatomical reduction, rigid internal fixation, preservation of the blood supply, and the early active movement. They did 487. They got 98% union and only 3% sepsis. Very, very good results by applying the early points for the AO. They, after that, published these ideas to all over the world to apply these rules. And in Egypt, I started my first AO internal fixation with my dear Professor Hassan Zahar, as I told you, and we apply the same principles in Egypt. AO technique was adopted, as I told you, by the world in 70s, but in Glasgow, 30% sepsis, 20% non-union, treating tibial shaft fractures by plating. In St. Thomas, 20% sepsis, 20% non-union. This is a very bad results for the rules, and also in Egypt. And I told you that documentation is very important to get why this happened and try to solve these problems. So when you are wrong and doubt, we go for the instructions. We did anatomical reduction, yes. We did the rigid reduction, fixation, yes. But did we preserve the soft tissue, as you see? No. And what happens usually with new generation doctors, that they open the skin, soft tissues, and they get the bone outside from the periosteum. If you did this, you will kill the bone, because you know that the blood means the blood supply for the bones coming from the periosteum. So you don't try to separate the periosteum from the bones, because with this will lead to non-union and infection. So we don't respect here the soft tissues. And that's what happened also in Egypt and all over the world, and we get very bad results. So AO tried to change the concept of internal fixation by documentation. We usually see these pictures till now in Egypt. Too much emphasis on the biomechanics, you see. Many screws, as you see. We open all this skin and soft tissue, very big incision, skin incision, and usually periosteum is taken out and the bone is out, and this is the result. You see very long infected skin incision, edema, redness. All this will lead to non-union and infection. Also, due to bad biomechanics, the plates were broken. As you see, many screws, you see many screws, many skin incision, very long skin incision, and usually will lead to infection and non-union. This dangerous of too much emphasis on the biomechanics. So the evolution of the AO try to improve the biology by preservation of the blood supply. First of all, they try to redesign the plates, because you know that when you put the plate on the bone and you put your screws, you will prevent the blood supply for the segment of bone under the plate. And this will lead to what is called segment necrosis. So the plates devitalize the bone by pressure on the periosteum and the underlying bone. If you reduce the footprint of the plate, you will kill less bone. So they redesign the plates for biological healing, what is called low contact dynamic compression plate. They go for the undersurface of the plate and they put footprints like the football shoes. So the plate will press on these points, on these footprints, not all the segments. and will permit the blood supply to go between these footprints. So I try to preserve the blood supply and the biology of the bone, and this in favor of union and decrease the percent for infection. And also, to improve the biology, we have to change the surgical techniques. All this is new concepts of internal fixation. Open reduction will devitalize the bone, so we use indirect reduction in reduction of bones, and this is more soft tissue friendly. Don't open very big incision, but only a small incision with indirect reduction to preserve the blood supply and soft tissues. We don't need anatomical reduction for all the fractures, but we need anatomical reduction for intra-articular fractures only to get full range of movement after operation. So intra-articular fractures only need anatomical reduction. But in shaft fractures, we need only to restore the length, alignment, and we don't accept rotation. So the aim now is anatomical reduction for the intra-articular fractures, and for the diaphyseal fractures, we need length, alignment, and we don't accept rotation. To improve the biology, we must change the mechanics. If callus is a good way for bones to heal, and it is in cases of diaphyseal fractures, then a bit of movement at the fracture site will stimulate callus formation. So in diaphyseal fractures, we need a bit of movement, but not excess movement. Otherwise, we'll end by pseudoarthrosis and non-union. No, just a bit of movement which is calculated biomechanically that will stimulate callus formation for diaphyseal fracture. So in cases of diaphyseal fractures, I must look for callus formation. But in joints, no. After that, the principles were changed again. The four rules were changed again. So there is usually a continuous change of concept of internal fixation. So what are the new rules? Instead of anatomical reduction for diaphyseal fracture, they asked for functional reduction. Change now. Number 2, stable fixation for the articular fractures, but still preservation of the blood supply is number 3. And number 4 is the early active immobilization. So this was applied since 1990. And also, AO did documentation of all the cases all over the world to documentation center, Muller Documentation Center in Bern, Switzerland. Functional reduction for metaphyseal fracture, starting by opening the fracture, and we have the long plate, as you see here. We fix the fracture from one end and the other end, and leave this area for callus formation. union bicallus fracture. And this is splinting. Will splint the fracture till these spaces will be filled by callus formation. This is called functional reduction, and the union here will be by callus formation. Also, intermedullary nailing starting to appear. We have only before is the Kushner nail, but now gamma nails, interlocking nails, and all other master nails, professional, many types of nails appear after 1990. That's evolution of the ideas of AO. This will splint the fracture, and the union here will be with callus formation. After that, evolution of the principles were also changed. And this are the final evolution till now. He put the biology number one now is paramount. Before he was the third point, now he is the first point. Minimal access surgery for the fracture, that I did small incisions and I go for plating without opening all this incision, but only a small incision. Our plane for the minimal access, it is extra periosteal but submuscular. Extra periosteal, we leave the periosteum on the bones for the blood supply and the blade and the muscles. So we go for the plane between the periosteum, extra periosteal, but submuscular. Also, we have what's called the minimally invasive osteosynthesis. And Professor Ahmed Allam, I think, will speak after me about minimally invasive techniques. The most important joint and improving point was the image-guided surgery. Before, we don't have this image. We usually did portable X-rays during the operations and go see and go and change. After introducing the image, now it is more easy for the surgeons to get good results now. But not in Egypt, unfortunately. But in the last AO trustee meeting, Siemens introduced the CT image inside operations. Last trustee meeting, Siemens also introduced the evolution by three-dimensional CT inside the operating room. All this will impact on the results of our operations, and this will lead to success for the care of our patients. So these facilitations will facilitate to the doctors the success of their operation. Also, arthroscopic assisted surgery like upper tibial plateau fractures, we use the arthroscopic assisted also to treat any injuries inside the knee while fixation of the upper tibial plateau fractures. So we have to preservation of the blood supply, functional reduction for diaphyseal fractures, stable rigid fixation for the articular fractures, and early active mobilization to get full range of work. By the end of my talk, I would like to thank again Professor Dr. Muhammad Al-Ashhab for giving me the chance to put my talk about the changes of concepts of internal fixation, and the final points we are now using. And I think after some years or something like that, these concepts will be changed again. There usually, by documentation, we get new ideas for improving our techniques, our biomechanics, and this will impact the result of our operations to our patients. Thank you all, and meet you again in next meeting. And if you have any questions, you can send it to Professor Muhammad Al-Ashab, and we shall answer after the our session. Thank you very much.
Thank you so much, sir. Thank you so much, Professor Alaa Elzoheriy, for this very interesting talk about the change in the concept of internal fixation that, of course, improves the results of fixation and the overall overcoming results. Thank you so much, sir. We are waiting for questions. If any questions from any of our attendees. We have a question, the violation of the AO principles. What is this sentence mean, sir? Professor Alaa, you are muted, sir.
Thank you. Yes. Evolution is تطور, improving. Evolution.
No, the violation of the AO principles.
Violation is the impact of the AO principles on our patients.
Yeah.
Is there any other questions?
Any other questions? We can move to the next presentation, sir. And if you are with us, any questions, we will be glad to receive it. Now we come to the second presentation, Dr. Thank you so much, Professor Ahmed Alam, for this very interesting talk. And now we are ready to receive questions from our dear attendees. We have a question to Professor Alaa Elzoheriy. Is submuscular technique plate should be small through small incision?
Yes, this is what's called this invasive technique. We make a small incision and we go in the plane between the extraperiosteal but submuscular. By your finger, you can give way to your plate in this plane, but not use incisions. By your finger, just the plate will go inside this plane, extraperiosteal but submuscular.
Yes. Another question to you, sir. Strain peri theory for healing. He wants an explanation of strain peri theory for healing.
Strain, yes. If we put some stress on the fracture, what's called is bit of movement. The allowed 0.2 millimeter in all directions will stimulate callus formation. But if more than this, will change into non-union and pseudo-ulcers.
Yeah. Another question for you, sir. In case of distal tibial fracture, do you apply cast with screw fixation?
Not full cast, but just the posterior slab.
Yeah.
And the elevation of the limb to decrease the possibility for edema and apply for good circulation. And we don't apply full weight bearing, but partial weight bearing by some crutches or something like that.
Yes, sir. We have
otherwise we get the stiffness of joints. Our aim is equalization.
Yeah. We have a question to Professor Alam. Where is the exact site of tibial plateau rafting screws?
Exact site for tibial plateau, what, please?
Rafting screws.
Grafting?
Rafting.
Drafting screws. You should position the screws according to the position of the fragment. Sometimes you have the fragment more anterior, more posterior. You should centralize it as much as possible, being at least 1 centimeter subcondylar, and you can add another screw which is called the anti-glide one. But you should be in the center or the body of the major fragment. You should always have at least 2 screws.
Yes. Another question to Professor Alaa. How easy getting fractures in good reposition?
After reduction?
Yeah, how easy getting fractures in good reposition?
Yes,
after
we try
reduction.
as possible for the articular fracture is anatomical reduction. Either it must be by open reduction.
Yeah.
All articular fractures must be reduced by open direct visualization to all the fragments to return the anatomical position of all the fragments, what's called anatomical reduction. But in diaphyseal fractures, we just need an indirect reduction.
Yes.
And for preservation of the lens alignment, and as I told them, no exception for rotation. Lens and alignment, but no rotation.
Of course. Thank you, sir. Another question to Professor Alaa. Would you mention, please, the principles and rule of Kappanji in distal radius fixation?
In fact, Kappanji percutaneous pinning is an excellent technique for reduction of distal radial fractures. You usually have to put 3 K wires if you make a pure Kappanji. In the examples I showed to you, you have a mixed Kappanji with other techniques. It is not a problem. But if you want to make a pure Kappanji, you should start with a radial pin. You enter your K wire with your hand directly from the lateral side, direct perpendicular to the fracture side. Just to enter the distal radius, move nearly to the middle of the radius and redirect it, the wire, proximally toward the elbow, about 70 degrees. By this maneuver, you elevate the distal fragment or the distalloid up and restore the radial height, and push it with your hand to feel the medial radial cortex, then complete with the power to penetrate the medial radial cortex. This is the first wire from the radial side. Then you should have at least 2 dorsal wires, one opposite the scaphoid, one opposite the leonate, because you usually have a dorsomedial cornal fracture. Even with ligamento-taxis, this dorsomedial fracture doesn't restore because it is devoid of ligamentous attachment. So you put a dorsal wire in the plane of the scaphoid to elevate the main radial fragment, and another one in the plane of the leonate to elevate the dorsomedial corner or the die punch fracture. You do it with the same technique, perpendicular to the fracture side till the middle of the lumen or the cavity of the radius, redirect it proximally, more or less vertical, about 70 degrees, push it till you engage the radial cortex, and then penetrate it with the power reed, the power source.
Yes, we have. Yes, sir. Thank you. We have a comment from our dear Professor Muhammad Abdel Al. To operate early in distal, in tibial plateau, is a term to be revised, as most of these injuries are accompanied by soft tissue injuries, whether evident or hidden. So the very famous statement, span, scan, and plan. What's your comment, Professor Alaa?
Yes.
Alan,
Alan Dr. Muhammad.
تفضل دكتور علاء بيه. تفضل استاذ.
Yes, you know the new theory from Muhammad about the classification of upper tibial plateau fracture, what's called the 3-column classification of the tibial plateau fracture. Now we don't depend on Scheisker classification. Scheisker now finished his classification, And then now the new classification is the 3-column theory. That is the lateral column, or what's called the valgus column. Medial column, which is called the varus column, and the posterior column. All columns must be treated, each one by one plate alone. The medial by a plate, the lateral by a plate, and the posterior by a plate. There may be a combination between 2 columns, or 1 column, or 3 columns, but you put the idea that each column must be by its incision or combined incision, but must be fixed. Before fixation is the reduction. How to reach the reduction? You must span by traction and anatomical reduction, because this is a joint. So you must put this in mind, that you must do anatomical reduction, then fix each column alone with preservation of the soft tissue, because this area is very vulnerable for compartmental syndrome. You know that the vessels, popliteal vessels, after division into anterior and posterior branches, will pass from the back of the knee to the front of the leg in the upper tibia through an opening in the periostal opening. The vessel will go through this opening to the anterior compartment. If in this area some collection of blood or hematoma or pressure by a tourniquet or something like that, this will lead to ischemia of all the lower limb. So we must scan, and good reduction, rigid internal fixation, but the reduction must be anatomical reduction.
Yes, sir. Thank you, sir. We have, sorry, we have lots of questions. Another question from Dr. Muhammad Ali to Dr. Professor Alam. In articular fracture, do you use screws only? Do you think that using screws only can withstand fractures or withstand loads, I think he mean?
Yeah. When you use enough screws supporting all major fragments, and you protect these screws for reasonable time, whatever, by avoiding weight bearing, supporting slab, bridging external fixator, yes, it is enough, because the healing rate is better than or faster than open reduction. So if you have screws in the proper position, and as Professor Alaa said, with anatomical reduction of the joint surface, it is a cancellous area. It heals rapidly. When you protect it well, yes, it can withstand the stresses.
Yeah, we have another very nice question. In tibial plateau fracture, if it is depressed, how to reduce it in a closed manner?
At the X-ray I showed to you, you make a very small incision, just a half centimeter, and introduce a heavy key wire, or you can introduce a little broad instrument like an periosteal elevator, small one, or a blunt dissector below the depressed fragment under C-arm control, and you push it up. This is an old technique, and all of us do it. It is not a difficult one, but the most important is after you elevate this, if you don't fix it, it will fall down again. You push it up. When you are sure it is in the joint line level, you transfix it with a K-wire, and either do the mode of fixation you want to do, or put the graft in it and fix the graft also with another screw or K-wire.
Yeah, I'm sorry, Professor Ahmed, I have a very nice technique. I did it with the depressed type tibial plateau fracture. I put a K-wire in an oblique manner and making it like a joystick, and elevate the depressed fragment, and they put another K-wire and cannulated screws is put in it. It's very easy and very simple technique by manipulating the depressed fragment by the joystick technique, and it gives excellent results.
Very good.
What do you think about it?
Yes, as Dr. Alaa said, everyone do the thing that he thinks that he can do it well.
Yeah.
This is not firm rules. The tools you can do it, you master well. you should do it. You are better in this area, Dr. Alaa is better in this area, I am better in this area. The technique you are mastering well, giving you good result, is the best technique you should do.
Yeah, you mean that in a very simple fracture or even complicated fracture, there is nothing called the unique solution of this fracture. We have many solutions of just one kind of fracture.
Yeah, there is no one solution for everything.
Yeah, yeah, of course.
Every fracture, I always say that every fracture has its own personality, and you should deal with its own personality.
Yeah.
How many times you face a fracture that is not classified?
Yeah.
Not fitting to any classification you see.
Yeah.
What about this, Dr. Alaa?
Yes, I agree with
Many
you.
fractures not classified.
Yes, yes, many fractures, yes.
Yeah. Professor Alaa.
And multi-trauma patients or polytrauma patients, usually many fractures, many types of fractures. And in the same patient, you can use different techniques.
Yes, of course. That's absolutely right.
Open fracture, closed reduction. Yeah, you see, every patient by his or any part of the patient will, in this case, will take one of the techniques.
Yes.
Professor Alaa, in case of distal femoral fracture treated by screws, what type of stability when bear weight?
As Dr. Ahmed Allam said, it is not only screws.
Yeah.
Not only screws, because the shearing forces after operation will break and destroy the screws. Yes. After either you put a neutralization plate by less invasive technique, or as Dr. Ahmed Allam said, you can put external fixation or plaster. But I think external fixation or a plate is better than plaster because we need early mobilization of the joint.
Yeah. You're right, sir, of course. That's what Dr. Muhammad Al-Mahdi said in his comment. Absolute stability for joints, not done by key wires, so need neutral plates with interfragmentary screws. What do you think, Professor Allam?
Absolute stability for joints, for cancellous bone, in my opinion, from my own experience and a lot of other personal experience, is not a must. Again, it is a stable fixation, which is protected enough till union, is enough. It is not a must to have rigid fixation in articular fractures. Just stable with enough protection.
And another question about the how long do you keep your patient non-weight bearing after percutaneous fixation of distal tibial fracture?
For distal tibial fractures, usually 5 to 6 weeks. But for plafond fractures, usually 3 to 4 weeks, you can start tip to touch. And it is also a matter of a change according to the personality of fracture and the progressive union you notice in X-ray.
Yeah, thank you so much. We come now to the end of the questions. At the end, I would like to express my deep thanks from the bottom of my heart to our great professor, Professor Alaa Elzoheriy, one of the cornerstones of EO in Egypt and Switzerland. Thank you so much, sir, for being with us tonight. شكرا جزيلا أستاذنا الفاضل.
Of wishes to all of you and all our colleagues in Benha University, and usually we hope more and more for scientific events from Benha.
والشكر الجزيل موصول لحضرتك يا أستاذنا, to my dear brother and my dear friend Professor Ahmed Allam for his very interesting talk about the mini invasive fixation of big joints fracture. Thank you so much, Professor Ahmed. وده ختام المسك بالنسبة لكورس الجنرال تروما. احنا هنبدأ إن شاء الله next Wednesday يوم الأربعاء إن شاء الله مع upper limb trauma course. It's a very scientific course, very condensed course, about 3 weeks. معانا في الكورس الupper limb معانا speakers من كل الجامعات المصرية, معانا speakers من USA, معانا speakers من UK, معانا speakers من ألمانيا, من إيطاليا, من البرازيل, من أيرلندا. فإن شاء الله هيكون very fruitful and very scientific course. الله يبارك في سيادتك يا أستاذنا, بوجود حضرتك يا دكتور علاء بيه.
عاوزت أي حاجة أنا في أي وقت معك.
ربنا يخلي حضرتك يا فندم، متشكرين تواجد حضرتك معانا، شرف كبير لنا يا فندم. فإن شاء الله نشوف حضراتكم يوم الأربعاء في بداية كورس الأبر ليم. Thank you so much Professor Alaa. Thank you so much Professor Ahmed. And have a very good night. Thank you so much.
شكرا دكتور
تصبحوا على خير.
علاء.
شكرا دكتور علاء بيه. تصبح على ألف خير يا فندم. شكرا دكتور أحمد.
مع السلامة.
تصبحوا على خير يا فندم.
كنت أنا مع السلامة.